All right. Okay, that's fine. Okay, I'll tell you briefly about arrhythmias in that case. All right. But let me tell you one thing. Know the terms. We have a lot of classification of arrhythmias. So you'll be familiar with the terms and the drugs used for it, be it from a medicine point of view or from a pharmac point of view. Because remembering the detail of it can be mind-boggling. So don't try to go too much into the details of it. Yeah. First, what do you understand by the definition or the term arrhythmias? What do you mean by this? In simple, it is a deviation from the normal rhythm. Heart has a rhythm, right? When there is going to be a deviation from that normal rhythm, it is called as arrhythm. So when the heart is not in its normal rhythm, we call it a cardiac arrhythmia. Now for this, before you could get into the different terminologies, I have a simple MCQ. What is the normal rhythm of the heart? Or the normal heart rate? Beats per minute. Yeah. Now, this is normal. Usually it is not 72 in every individual, right? It's a range. If I had to give it a range, I would give it anywhere between 60 to 100. Okay? That's normal. Depending on the age, weight and whatever, different reasons, we give it a range called as 60 to 100. Now, when the rate drops below 60, what is the term we give for that? Brady. We call it as bradycardia, but you could also refer to it as bradyarrhythmia, because again it is a deviation from the normal rhythm. Correct? So here the heart rate has gone down, it has gone below 60. We have a term again when the heart rate goes above 100. What is that? Yes, we call it as tachyarrhythmias. So now we know what is tachyarrhythmia or tachyarrhythmias, right? Okay. Now again we have further classification in this. This is just a broad classification. When 60, so we have 40 to 60, 20 to 40, and when it is less than 20, we call it as mild bradyarrhythmia, moderate bradyarrhythmia, less than 20 becomes severe bradyarrhythmia. This can reach even 0. That's the further classification of bradyarrhythmia. In tachyarrhythmia, okay. I have a little lack of space, we may find things here and there. When the heart rate is anywhere between 100 to 150, we call it as simple tachyarrhythmia. Getting it? When it is anywhere between 100 to 150. When it becomes more than 150 until like 150 to 250, you call it as paroxysmal tachycardia. Why the term paroxysmal? Because sometimes it is there, it vanishes, comes back suddenly, unpredictable, so we call it paroxysmal tachycardia. Now when that reaches about 250, so when it is between 250 to 350, we call it flutter. When it is beyond 350, we call it fibrillation. The severest form of tachycardia being fibrillation, and fibrillation common in the ventricles, and ventricular fibrillation is the most common cause for sudden death in humans. That's your MCQ. Okay. Are we clear on this so far? Okay. Now relate this to, yes, I'll repeat it. We have seen different types. I'll tell you. We have seen different types where you can have simple tachyarrhythmia, we have paroxysmal, we have flutter, we have this and that. Put it to just the atria or the ventricle. Now suppose flutter happens in the atrium, we call it atrial flutter. If it happens in the ventricle, we call it ventricular flutter. So each of these things, when it happens in an atrium or in a ventricle, we prefix that and call it as a ventricular fibrillation, atrial flutter, and so on. That's fine. So put the name of the exact structure that's involved and you get the different types of flutter and fibrillation. So in that you can have atrial fibrillation and you have ventricular fibrillation, and ventricular fibrillation happens to be the most common cause for sudden death. Obviously, think of it, the heart rate is even beyond 350. It's hard to expect a human to survive. I mean, it's quite a severe condition. So it can result in sudden death, and that happens to be, among all the arrhythmias, ventricular fibrillation happens to be the most common cause for sudden death. Okay. Is this clear? Difference between a flutter and fibrillation. Flutter is 250 to 350 range. When it is beyond 250 up to 350 is flutter. When the heart rate goes beyond 350, we call it fibrillation. Now, the definitions that you see in your keynotes is exactly what I have told you in this representation here. And if you're clear with this, I think the definitions should be fine. Are all of you clear with this? Any doubts here? Yes, Saurabh, tell me. Paroxysmal is when the range is between 150 to 250. Up to 250 beat, we call it paroxysmal tachycardia. If it happens in the ventricle, it will be paroxysmal ventricular tachycardia. The reason why we call it paroxysmal is it has a sudden appearance and a sudden disappearance cycle. If you look at just the general meaning of paroxysmal also means appearing and disappearing. So it comes and leaves. It's not continuous. It's not like it's always present. It could be present at times, it comes. You have a sudden increase in the heartbeat at times and then it's not there for some time. So that is what is paroxysmal. The rate is between 150 to 250. I think I have to write this thing is causing you confusion. Wait. More than 350 is fibrillation. between 250 to 350 is flutter, between 150 to 250 is paroxysmal, and between 100 to 150 is simple tachycardia. The basic difference lies in the rates, which is also there in the explanations in your thing. So you read them, you will be able to follow them. We'll just read about extrasystole. I'll have to give that explanation to you in the next session. Extrasystole is a premature beat because of an abnormal automaticity or after depolarization that is arising from an ectopic focus. Okay, I'm sure this needs explanation. You need to log out and log into the next session. If there's any doubts in what we have done so far, you can ask me. Alright, I think your question, I don't see any doubts. Log out and log in, the next session is at 8:05. I'll be closing this session. Yeah. Okay, now let me tell you what an extrasystole is. What is this? What is this, all of you? Action potential? Not really. Well, I'm not really trying to depict the ECG, but the normal action potential and how it progresses. Okay. Now, the line that I have below, that will be my resting membrane potential, alright? And this is going to be the threshold potential, after which the peak develops. So that's representing your depolarization. This phase represents repolarization, and this one is hyperpolarization. So if all of you are familiar with this action potential, now let me show you one diagram that will simply explain to you what extra beat or something is. Hyperpolarization is when repolarization progresses and what do I say? Hyperpolarization happens because of potassium. Lots of potassium goes out, and that causes hyperpolarization. Guys are able to see this extra thing that I have drawn? Okay, if you compare, let's look at the normal action potential. You see, it starts from the resting membrane potential, right? After a certain threshold, it takes a peak. But do you see, this is an extra beat. Okay, we call it as a premature beat because it doesn't really start from the resting membrane potential. It seems to be starting somewhere in between the action potential, right? It's a premature action potential, so we call it as a premature beat. Are you guys able to follow me on this? Yeah, and also this is depolarization, correct? And this extra beat, this extra beat has been produced after one depolarization, correct? The normal depolarization has taken place. So the extra beat has occurred after a depolarization. So you actually call this phase when you have an extra beat being produced after a normal depolarization. So we call that as an after depolarization. This term that you see here, it's an after depolarization. It is premature. It comes from suddenly in between your normal action potential, and it comes after a depolarization. We call it as an after depolarization. Now, why does this happen in the first place? It can happen because of an abnormal atomicity. All of you know what is atomicity? It is the ability of your heart to generate action potential on its own. So the only sign where this can happen is in the SA node, because it's only the SA node having the ability to generate its own impulse. Now, when over there abnormal atomicity happens, the node has become abnormal in developing its own action potential. It starts developing rapid action potential, then you have a after depolarization. Now again, depending on the site it can be, that is if it happens in the atrium, this is called as an extrasystole. It's an extra beat, and this happens during the systole, so we call it extrasystole. If it happens in the atrium, it's atrial extrasystole. In the node, nodal. If it happens in the ventricle, it is ventricular extrasystole. And when you take the ECG of this, you'll find that the QRS complex in VES, that is in ventricular extrasystole, is broader. Are we clear with this? All of you got it? Can you hear me? And has this concept been fine? Okay. Saurabh is not clear. Saurabh, you understood the production of this extra beat? All of you understood this extra beat? How can it, the heart is becoming abnormal? Okay. You need to know why. 4 chambers, SA node. Okay. There is something called as an ectopic focus. Ectopic focus means that apart from the SA node, there is another point which has become able to generate its own action potential. Now think of this region is generating an action potential. When this is generating, it has to travel from the SA node to the AD node. At this point, I have an abnormal tissue over here, which for a reason or some reason has developed the ability to generate. It gives another beat over there. Then your AD node is receiving 2 beats. It is receiving 2 action potentials. One is the normal one and one is the premature one. So that premature, now depending upon which location, whether it is in atrium, ventricular or whatever, for it is a premature beat. It's also called as after depolarization. Everybody clear? Next we have paroxysmal. All of you already know what is PSVT now. You know what is paroxysmal tachycardia? It is above the region of the ventricles. If I have to draw a heart, it's going to be somewhere here. So above the ventricles, so that is why supraventricular tachycardia. So the rate is 150 to 200 and conduction velocity remains 1:1. And this PSVT, we will be referring to this as PSVT, can occur due to surface movement type of re-entry, and or it could be through an accessory pathway between atria and ventricle. So frankly, these things are only for your understanding. You guys want me you want me to explain these two things to you, or you would like to by heart it? I'm okay with both ways. But if you want me to explain, you got to give me some time and you got to give me your concentration. See, nobody is going to ask you what is circus movement, or nobody is going to ask you what is Wolff-Parkinson's thing. But there has been an MCQ on PSVT. Drug used in PSVT has been asked. Okay. Circus movement. Okay. One second. What is the mechanism of developing this arrhythmias? How really does it, we know that it is an extra beat, right? We know that it is increased number of beats being produced. But in terms of why that beats being produced, right? So for that, there are, we will be saying that, Pankaj. So in terms of the mechanism, especially for ventricular, more often for PSVT, okay, the mechanism happens to be increased automaticity. All of you already are familiar with. Can you concentrate on this? We will be dealing with drugs. There's a big long chart that is present over there. I already told you. If you want me to tell you this, I need you to concentrate. Alright? Now, all of you are familiar with what is automaticity? Ability to generate its own impulse. Okay? That increases. Now, how can this increase? When you give epinephrine, it can increase. I'm just giving you one example. There may just be many. Okay. When you give epinephrine, you increase automaticity. So the rate at which the SA node, this functions at the SA node. So the rate at which the SA node is generating impulse becomes rapid. It does not remain 72 beats per minute anymore. Okay. So there is a lot of sympathetic stimulation that is happening. Sympathetic stimulation increases automaticity. Alright? That's one mechanism. Other mechanism is circus re-entry. That's what has been told over here. What is circus re-entry? Now in the normal heart, we will talk about the normal heart first, okay? You can have anatomic obstacles or you could have pathologic obstacles, right? What are these obstacles that I'm talking about? Think of an opening or a broad division. In case you, now even you take for the normal heart, you have the central AV node. Any impulse that will come through it will have to go round it. I mean, if there is any division, now think of a blood vessel dividing. It's not going to pass through like this, right? It will have to go round it. Go with the flow basically, right? So we're talking about such natural obstacles or pathologic. Pathologic may be a scar tissue in the heart, or it may be a thrombus or something. Basically, when we talk about obstacles here, we are trying to think of a tissue which cannot permit conduction. Are we clear so far? All of you understood? When we talk of an obstacle, we are talking of a tissue or an unwanted thing, whatever, which doesn't allow impulse to pass through it. It has to go around it. Now such kind of a thing in the heart can be natural or it can be pathologic. We would just be taking a diagram like this because it gets easier to explain. Okay. That's my normal obstacle. Now think of impulse here. Impulse can move in this direction and it will move in this direction, correct? And it will move at the same rate. Because it cannot pass through it, it moves around it. They meet at a point like this, beyond which, because they are moving at the same rate, they cancel each other. So I think we cancel each other and don't go as two impulses, but they would just get eliminated like that. The path becomes same. Alright? This is what happens in a normal scenario. Let's take the same thing in, yes, that's normal. We have a similar obstacle here, but in addition to this, I have a problem here. See, if you look at this here, the tissue is absolutely normal around the obstacle. The muscles, the blood vessels, everything is normal here. Okay. But in my thing, like this happens in case of a pathology. I either have an infarct tissue, or I have a scar, or I have a degenerated muscle. I basically have some problem over here. Okay. Again, this tissue cannot conduct. Either its conducting capacity has reduced or it just cannot conduct. So far clear? All of you able to follow me? I don't see all of you responding. Is there any doubt? Do you want me to repeat on this? Okay. Now, think of the same thing. I have an impulse coming. It comes here. Okay. I also have this here on my right side. For my right side. Let's name it as right side here. On the right side, there's no obstruction. Absolutely clear. It comes to this point with no problems. But here, since the tissue is not able to conduct it, alright, and also what happens is the tissue tends to have something called as a refractory period. All of you are familiar with the term called as refractory period? One action potential generated depolarization, repolarization, and in the time taken between two action potentials. Okay, so during that refractory period, no matter how much stimulus you give, it will not respond. Okay. What happened meanwhile here is the tissue here, the particular red tissue here, is still in its refractory period. So even an extra impulse coming in is not really able to stimulate this. So in any case, it's not able to cause the impulse generation to take place. What happens here is a beat will go down and will also go like this. See, I'm not saying that all the beats take two routes. Not all of them. Okay? Some may go down while some may go back, retrograde. Okay? When it goes retrograde, it means this new, the impulse. Please remember that a continuous new impulse is going on coming. Okay? So every time the old impulse comes here and meets the new is being created over and over again. So it's going round and round that circle. So that's called as the circus phenomena, and also called as re-entry. Why re-entry? Simple. You have an impulse being coming from one side, and then it go back again, retrograde. That is why re-entry phenomena. So we call it as a circus re-entry. Natural obstacle may, it comes from side A, side B, and they flow through normally because of no obstruction, and they get passed on to the next muscle. There is no necessity of a backward cycle here. See this, okay, let me tell you one thing. This is an obstacle which cannot conduct tissue. It is not conducting it in this manner. That is why the tissue is going around, that's why the impulse is going around it. But an impulse which is generated on the B just goes out. It does not enter cycle A in the natural or normal conditions. Okay, that particular thing happens when there is a pathological problem with the tissue. The obstacle remains. This obstacle just remains, like it could be an artery dividing. It could be a node. Right? Are you guys able to understand? This is not the obstruction, guys. The obstruction is this. This is just a normal way of how the impulse goes. The actual obstruction is this. It is this piece of pathological tissue that is causing the problem. This obstacle is normal and that remains, and that is not a pathological obstruction. It is an anatomic obstacle. It's something that is there in everybody. You know, you think of an artery. An artery is dividing like this. You could have an artery dividing like this. Then in that case, don't you have this kind of a division happening? Okay. I think Jinky's question is, how is it going, crossing it? It is not going through the obstruction. There is a new impulse that is going around the obstruction. That's the piece of tissue. Okay. And okay, your question is, why can't it come like this? Okay, that is if it is a small piece of, okay, now that is if it is a small portion that is affected. That's because I have drawn a big diagram to explain to you. Now imagine a scenario if it's like this. It stops, the impulse stops over here. Okay, and then this particular thing, see, the main problem here is you have, that also can't re-enter. Yes, it cannot re-enter, but you should understand that the tissue around is in refractory phase, and the tissue does come out of the refractory phase. Even the pathologic tissue could come out of the refractory phase, while the tissue which is around it can also come out of refractory phase. That's one principle. Another thing is you have a constant supply of new impulses that is coming in from here, which does make your impulse stronger, so it does go around the tissue. That is how it goes around the tissue and develops a circus. It keeps going round and round. It will go like that. Beyond it. It will go beyond the tissue. And when the tissue falls off its refractory period, it may allow the impulse to pass through it, but that happens very rarely. Okay, everybody got the circus phenomena? Okay, let's do WPW syndrome. All of you still with me? भाग तो नहीं गए कि आज कुछ ज्यादा ही हाई-फाई चीजें हो रही हैं? If at any point you guys feel it's going beyond your understanding, please tell me. We could make it more simpler, alright? What is WPW syndrome? Okay. My diagram of the heart is not very good. Okay, nice to see you guys smiling at least. As long as it looks like a heart. Okay. It's very difficult to draw with the mouse for me, so please, as long as you find able to, imagine it as heart. What cycle? What cycle, Rinki? I'm not sure what cycle you're asking about. This is re-entry. Circus re-entry. It's one of the causes or mechanisms of how ventricular arrhythmias happen. Cause for ventricular arrhythmia. Supraventricular, PSVT, paroxysmal supraventricular tachyarrhythmia. Okay. Now what happens in, tell me one thing. What's the most, what really brings about a communication between the atria and the ventricle? What establishes communication between the atria and the ventricle? Not in terms of physical, but I'm talking in terms of, not what establishes connection. Connection, bundle of His, very good. Okay, you have bundle of His and you have the impulse moving from the SA node to the AV node, which then goes. So that's how communication normally happens, and maybe then physically from the valves. Right? But sometimes there could be another way, an abnormal communication that can exist between the atria and the ventricles. Okay? That's called as the bundle of Kent. Okay, so this extra communication can pass on. Now think of it. Atria gives a signal. The signal that comes from atria goes to the bundle of Kent, and Kent also gives signal. So isn't the ventricle receiving extra beats in the process? Understanding the point? As far it is from atria to ventricle. It could be anywhere. It doesn't have to be from one atria to the same ventricle. It is an extra communication. I've just drawn it for diagram's sake. It could be even like this. Okay, it could even be like this. It's a communication between atria and ventricle. Now this communication obviously transfers extra beats to the ventricle. Right? It is a bundle of Kent. What is bundle of His? So if you have something as bundle of His, it's again a collection of fibers which will help in transmission of impulse. So it's muscle fibers which are establishing that communication. Okay. Did all of you understand? So what is basically happening in this? There is increased rate. The kind of they have here again is a ventricular tachyarrhythmia. These patients with WPW syndrome will experience frequent ventricular tachyarrhythmia, and it will be severe, right? And so this extra bundle of Kent that has formed, isn't it an accessory pathway? It's an extra pathway, right? Apart from the usual pathway, it's an accessory pathway. So when you look at the definition of WPW syndrome, what does it say? It's the extra increased heart rate or an extra impulse produced because of an accessory path. So patient experiences frequent and severe ventricular tachycardia. Bundle of Kent is basically formed by bundles of fibers. So yes, physical and yes, call it a physical communication to help in impulse transmission. That's all is WPW syndrome. So I think we'll get back to yes. So let's get back to where we were. We were talking about PSVT, and now you know why PSVT happens. It can happen because of circus movement, or it can happen because of an accessory pathway in the WPW syndrome. So I hopefully you guys understood what PSVT is. We already know what flutter is. Flutter is when there is a heart rate of about 200 to 350. This also happens because of a re-entry phenomena. And because it happens most commonly in the atrium, in the right atrium, we call it as the the atrial flutter. Commonly takes place in the right atrium. All of you still with me? Atrial fibrillation, we told you it's impulse being more than 350. When the heart rate goes beyond 350, so it's anywhere between 350 to 550. That's it. And again, when it happens in the atria, we call it atrial fibrillation. We have already seen ventricular tachycardia. I just go to torsades de pointis. What it basically means is twisting of points. Think of the action potential being twisted. So that's basically the normal ECG that you read is just going to be haywire, right? We call it as the QRS complex, right? When you read about it in the ECG, we read QRS, right? That's one complex. You may not really have that synchronized. It may not be QRS in its typical form. There's an absolute change in it. That's torsades de pointis. So obviously it is a life-threatening condition. It is the most severe form of ventricular tachycardia. So when you say the ECG, it is going to be different. Okay? And what is going to be different in this? There is going to be a long QT interval MCQ. And actually this is an MCQ more in general medicine, not in pharmac. But you do have this. In torsades de pointis, you have long QT interval. Ventricular fibrillation, also seen this. Most common cause of sudden cardiac death, MCQ. Okay, are we clear with all the types of, what we have seen so far is just types of arrhythmias. And I hope all of you are clear with that. Let's go to AV block. AV block is when the AV node is blocked. So no conduction being transmitted from the SA node to the bundle of His. And I have blockage over there. we have 3 degrees of block there. A very important MCQ in general medicine here, which is first degree block, second degree block, and a third degree AV block. In first degree AV block, the conduction is only slowed down, while in a second degree, there is no conduction, and in third degree, absolutely no conduction, and the ventricle starts generating its own impulse, and this is called as a complete heart block. No communication of impulse taking place from the SA node to the AD node. Ventricles come down to the level of generating their own impulses. That is a third degree block. Block is clear? Now, we have a classification of antiarrhythmic drugs. 4 classes. Beta blockers again come here. Calcium channel blockers come here. Unique in this is class 1 and class 3. Class 3 are those which widen the AP. Now what is happening in arrhythmias? AP is quick. Now what happens if I widen the AP? The time taken for one AP to depolarize, hyperpolarize, it's more. So you expect one action potential to be there for a longer duration. So the time taken for the next one to generate is more. So that way you widen it and prolong the repolarization. So that way you reduce the number of beats being produced. In class 1 is membrane stabilizing. They block the sodium channels so that not refractory period. They prolong the repolarization. Yeah, almost like prolonging refractory indirectly, yes. But the direct action is on repolarization. Going back to the sodium channel blockers, very simple. You block the sodium channels, no more sodium available to generate action potential. Go back and read these names. Again, by heart this chart. I have 2 important points over here which need to be marked up as an MCQ. Drug of choice for PSVT, many times asked, adenosine digitalis. Drug of choice for AV block, isoprenylin and atropine, very different. You're not using the regular antiarrhythmic drugs over here. You're using isoprenylin and atropine, sympathetic and anticholinergic drug for AV block. And okay, now I have this one crazy chart over here. Okay, what I suggest for both acute and chronic, read first choice thoroughly. And wherever there is cardioversion, it gets easy. Cardioversion is nothing but that, you've seen the dramatic thing that happens on TV, how they try to bring back a person's life. Okay, I leave this chart to you all to by heart. I know it's difficult, but there have been MCQs. And that's what I said. I think I can make it a little simpler by telling you to be thorough with the first choice, because otherwise to put the whole chart on you for the whole, it's okay. See, you already know a few things like if you see majority of it is cardioversion, so you actually have to come and read what it is in chronic therapy. Just do a lot of questions related to this, and you'll come across what has been most commonly asked, and then you can concentrate on what has been asked. And meanwhile, keep practicing it. It's okay. Huh? Then go to the next thing. It's